spoke with one of my colleagues today about this, or she growled at me about it more than I spoke to her. And that's just the concern about someone who might be 95 years old and has dementia in a nursing home, they have a low hemoglobin, and they have iron deficiency. It's not necessarily someone that we need to be doing invasive tests for. This slide was meant much more for the junior doctors than it is for you guys. But you need to think about the severity and recurrent nature of anemia, the risks that are associated with these investigations, and the fitness to withstand treatment if someone has cancer but their heart disease is so bad they can't have an operation. It may not mean much if you can find the cancer. Patient preference is very useful in this situation, and fortunately a lot of these patients would say, I don't want to have anything done anyway because I'm not fit to do anything about it. Post-gastrectomy we've talked about, and that doesn't happen anymore because when I was young, before there were a lot of good drugs, we used to chop out a lot of stomachs for ulcer disease. We don't do that anymore because we have great drugs and we can treat Helicobacter. But bariatric surgery, which I'm sure you've all heard about, this surgery to promote weight loss, it generally promotes weight loss because you're not getting enough stuff into you to keep the weight down, and some of the stuff that's not getting in is iron, particularly if it's an operation that promotes malabsorption, which some of them do. So we're going to see a barrage of iron deficiency associated with bariatric surgery. There's already some data on that. Helicobacter is the bug that's kind of famous because it causes ulcers, it does all kinds of things, but it also causes iron deficiency. We're not really sure why it causes iron deficiency, but some people who are iron deficient, you can't find the cause, but you find the Helicobacter, you treat that with antibiotics and their iron deficiency gets better. We don't really know why that is, but it does happen. And then we brought up this topic of iron deficiency without anemia. So your hemoglobin's normal, but your iron levels are low. It's 3 times as common as iron deficiency anemia. Now fortunately we don't see it very much because we only order the ferritin if the hemoglobin is low. We don't sort of start with the ferritin and then look at the hemoglobin. We start with the hemoglobin and then go to the ferritin. So we don't have to make this decision very often. There's not a lot of consensus on what you should do, but the thing that makes me feel a little better about this is that there's a very low prevalency of malignancy in people who have iron deficiency but have normal hemoglobins. I would tend to rule out celiac disease in people who have a high-risk profile. So if you're over 50, you've got a family history of colon cancer or stomach cancer, then I would tend to look into it. If not, I might consider just empiric treatment with oral iron for 3 months and then follow it. But obviously, if the ferritin, the iron levels dropped off again, then I would tend to look into that. So just the sort of take-home messages is that everyone with iron deficiency anemia should be screened for celiac disease. It's easy to do. It's a blood test. If you're not a menstruating woman, then you're probably going to get under the gun with an endoscope and colonoscope. You should get appropriate iron replacement, and it's not unusual for me to be called about someone who wants them investigated, and I say, are they on iron? No. Well, put them on some iron and we'll arrange the testing, but you really do need to get on iron. All those not responding to treatment should be considered for further investigation, and ferritin is the way to document iron deficiency. So if you have a low hemoglobin, you should be looking at that. And these are just some other things that I talked about already. Again, the algorithm for treatment, which separates premenopausal women from postmenopausal women, men, postmenopausal women and men. And that's all I have to say. This is an Ironman guy here, and I saw this fella, a triathlete, not long ago, but it is a while ago. And he was iron deficient, and when I saw him, we biopsied a small bowel and he had celiac disease. But we both sort of got a kick out of the fact that he was an iron man who had no iron. So, and now that he's on his gluten-free diet, his iron is back up again and he's going crack. Now, it never got him off the bike. He was just a bit slower, which is why he went to the physician. His physician the first place. But anyway, that's all I have to say. Thank you very much.
So I was going to invite our speakers back to have a little panel discussion if people had some questions. So,
All right, to start with a question, maybe, what's the chance of H. pylori reinfection?
It's pretty low if you get treated adequately in the first place. But so the standard treatment, which is 2 antibiotics and an acid suppressing medication, is effective 70 to 90% of the time. So generally pretty effective, but you need to know that that has been effective. So after you've been treated, you need to wait 2 or 3 months and then have a test done to see if it's been effective. If you've had effective treatment, the chance of getting reinfected again is pretty small. Most of us who've got Helicobacter pylori got it when we were young, and we were drinking carnation milk and doing all those kind of things that people don't do anymore because people have more money now. And Helicobacter pylori is actually a disease of low economic status, so that in developing countries it's huge. In North America it's dropping down because our diets are so much better now than they used to be.
Does it ever go away by itself, Helicobacter pylori?
I don't know definitely the answer for that, but I think it's no. I don't think it does.
Baby aspirin included in that?
Yeah, oh yeah, yeah. Yeah, so it's the effect of aspirin and non-steroidals on the GI tract. You know, someone could have a bad knee and just take Motrin for a week and end up with a bleeding gastric ulcer, and yet I can gobble them down as much as I like and I don't get it. So that there's obviously factors in terms of genetic predisposition and individual tolerance for these medications. But just these baby aspirins that you take for your heart are certainly sufficient. But if you combine non-steroidal agents on top of that, and then if you take prednisone on top of that, then that sort of, there's an additive effect there that makes you even more prone to have trouble.
You mentioned the daily aspirin. I do take the 81 milligram, just, stroke and heart disease in my family. Is that something that, again, I know you don't know specifically my case, but is that something that maybe I should not be doing?
yes, actually, because the guidelines actually have just changed.
Okay.
So the current consensus is there is not evidence that it's very bizarre, we don't understand it, but there's not evidence that aspirin works well in primary prevention. So if you haven't had an event, it's not that useful. Once you've had an event, it's extremely useful.
And can I just add, like what Dr. Fardy was saying, because I work at the Miller Center and we have seen elderly patients that are on daily baby aspirin and with severe GI needs. And before then, like there's no symptoms.
So we're talking Advil, Anaprox, aspirin.
All of them.
No,
Except Tylenol. Tylenol is
Tylenol's
fine,
one
it doesn't hurt you.
Okay.
Got it.
And I'm not sure if it was said, but I would really, really stress that it's very important if you're found to be anemic not to take iron unless you've been checked for a low ferritin. Because very rarely, but twice in my very long career, I've met people unfortunate enough to have been put on iron without an indication, left on iron, and who actually have totally destroyed their liver.
I think you need a firm diagnosis so that
And
if
you
you're
need
anemic.
follow-up. You shouldn't just be on iron and not get it rechecked.
What about hair loss?
Yeah, because one of the things that brought me to my physician was because I have had significant hair loss. And that's what brought me into my doctor. And from there, we're still not certain if it's direct result of the iron deficiency or if it's some other thing playing itself out. But I've never had it, and it's so I just wondering, is that commonly a symptom of related to iron deficiency, and what can I expect if it is?
It's definitely common, especially in young women. I had a lady bringing a bag of her hair. It was very sad. So patients get alopecia, so patches of hair, especially young women.
So is that something that
It gets better.
it can get better? Yes.
It grows back.
It does? Okay, okay. Because I have about 1/3 of the hair left on my head, and it's just, that's what brought me there to begin with, so. And I guess there's nothing else to do with, other than to just wait for the iron levels to come back up, you know, other than just, yeah, okay, all this would be
Low iron, but not anemia, like I've had, I guess, chronic low iron as long as it, and I don't know if it's related to menstrual periods or whatnot, but it's always been there. Would it be an idea for me to suggest to my family doctor to have a test for celiac? That's nothing I've ever felt as an issue for me, but.
Definitely, yeah. And it's only a blood test, so, and it's pretty cheap. But you might have to get ready for a gluten-free diet then. You may regret having found that.
Question is, like, would you have to have a bowel biopsy after if the TTG is high?
Yes.
Yeah, because that's really a gold standard for, yeah. One of my coworkers struggled with iron deficiency, and they finally did the TTG, and sure enough, but she had to buy a biopsy, and sure enough, she had celiac.
How do people all of a sudden decide to develop celiac disease?
Well, celiac disease is, I mean, the experts are all in Ireland, right?
Don't let me.
But the Irish guys that I've heard talking about celiac disease talk about the tip of the iceberg and how there is much, much more celiac disease around than we are aware of. And from my point of view, I'm torn on that, because I wonder if you, with just a low ferritin and no other trouble, do I want to know if you have celiac disease or not? Because if you do, then I'm going to put you on a gluten-free diet, and then you got all the pain and expense of that, which, I mean, it's tolerable, but you might have been a lot happier eating the things that you were eating now before you go on a gluten-free diet. On the other hand, you have these guys from Ireland who are saying that if you have celiac disease, that your risk of malignancy in the GI tract is increased, and that if you go on a gluten-free diet, you can actually decrease that risk. And we use that as leverage to get people to use their gluten-free diets. But I freely admit to patients that I've never seen anyone with celiac disease show up with one of these tumors.
Oh, we have.
Yeah.
We definitely have.
But I haven't seen very many.
Here or Ireland?
No, here.
But there's other medical complications with celiac, like with
There are.
bone health and other organ systems.
Certainly there are, but if you're otherwise well, then,
Yeah.
you know, this is kind of heresy.
Yes, yeah.
I have friends that, who doesn't have friends with celiac disease these days, but I have friends who have significant issues with, and once they were diagnosed, then it was a godsend to them. But then I have other friends who have that non-symptomatic, that asymptomatic celiac disease and didn't get diagnosed until they were in their mid to late 60s. And obviously they lived into the mid to late 60s, and it was only because other family members got a diagnosis that they would say, well, you should go and check it out, and sure enough, but they were perfectly fine on the outside until, but now they're following a gluten-free diet, but.
Let me forget about everything I said. You should get tested for sure. Because I don't want to be telling people the wrong.
Yeah. Well, that's called heterogeneity. So that's the whole mystery of life. The huge difference from one person to another with something that seems to be similar.
It's also important to say that if you have a TTG done, this blood test, and it comes back that you are positive, you still have to go to a GI doctor, but you cannot go on a gluten-free diet until that diagnosis is confirmed, because once you go to a GI person, they will say that you need to, if you took gluten away from your diet and didn't have any wheat, it's going to change the significance of the tests. And for the period of time that you were not taking any flour, they would say you had to go back and it had flour before we can do a scope.
To introduce it again.
So the test is not 100% specific for celiac disease, and it comes in different levels. So you can have a slightly abnormal level, or you can have a very abnormal level. The higher it is, the more likely you are to have celiac disease. We generally will put a light down in everyone and take a biopsy from the small bowel, which is the gold standard for making a diagnosis. Then when you look at the small bowel under the microscope, instead of having all these villi which are sticking up and sort of floating in the breeze like these sea anemone things that you see on TV, it's flat. You go on a gluten-free diet for 3 months, and then you look again and take biopsies, and then the sea anemones are all back there again. Right? So that we like to confirm the diagnosis with endoscopy, although there is some controversy about whether you really need to do that in patients who've got very high TTG levels. And the other thing is that if your TTG is normal, it doesn't necessarily mean that you don't have celiac disease. It's unlikely, and I think in your situation that would be a good enough test to do. But if you're having a lot of GI types of symptoms, then we won't rely on the TTG by itself, and we may go on and do further testing like a biopsy in that situation.
Do you do that for children?
Do we do all of that for children?
My little girl had a lot of GI issues as a baby, and she eventually, in age 4, had that TTG test and came back normal, so I said, thumbs up, that's great, let's go on our way. But she still does, on occasion, still have, I don't see a cause to why she has a lot of diarrhea or a lot of bloating in her belly and stuff. So,
We have a pediatrician.
Well, actually, yes, and the pediatric gastroenterologist was desperately
Would have been the
trying to come
best
here,
answer,
there's-
but I have a son who has celiac disease, and I tell you, when he was diagnosed, it was not common at all. Like, celiac disease wasn't that common. But now, when I see he was doing general pediatrics, I diagnosed 4 children with celiac disease because I was more aware of it. And anytime, and 3 of them were diagnosed actually with the iron deficiency anemia. And that's how I diagnosed. But with your child, the TTG is done. Was IgA done as well? Because the TTG test is only good if your IgA level is normal. So if IgA level wasn't done, so then the test could be normal. So I think that should be checked as well.
go back and have her recheck.
Yeah, and TTG could be repeated again. And maybe
And
that'll
then
give us
request
more
the IgA
information.
level.
And do the serum ferritin level. So if the iron level is low and your child's eating well, and the TTG comes back even slightly high than normal, then we have to really consider that should have biopsy done.
Okay, that's great. Thank you.
Just curious, what's the rates of false negatives for like standard tests and scoping from both ends and that, like fecal blood, for instance? What's false negative rate, and just for scoping, what's the chance of missing something with biopsies? What's false negative rates?
So if on the lower end, it's very dependent on the preparation. If the preparation is adequate, then and you have a properly trained and experienced endoscopist, then the chance of missing a cancer on the lower end, I would say, would be less than 5%. But nothing is perfect. But I would say it would be less than 5%. On the top end, even less than that, because preparation is not an issue, and the chance of missing a malignancy with a standard endoscopy, again with a properly trained and experienced endoscopist, would be very, very low, probably less than 2%. So, but none of these tests are perfect, and we all have to sort of keep that in mind when we're
And
dealing
fecal
with
blood tests? Like the
fecal
ones-
occult blood test.
Yeah, like the swab one.
So we don't use the fecal occult blood test for much anymore. The FIT test, which I alluded to, is the test that we're using in the provincial colorectal screening program, and Dr. McGraw is going to be so happy that I got to talk to so many people because he runs that program. But the FIT test, a standard fecal occult blood test, was not a very good test for looking for occult malignancy, even though it's called a fecal occult blood test. But the FIT test is an immunohistochemical test that is very specific for human hemoglobin, and it's very specific for hemoglobin from the lower GI tract and not from the upper GI tract. So the old test, if you ate a steak or you took an aspirin, your test could be positive. And sometimes you could have a cancer and the test would be negative. But this test is very sensitive and specific. Again, it's not 100%, but this FIT testing, if you're positive for that, you definitely need to have a colonoscopy done. If it's negative, the chances of having a malignancy are low, but the FIT testing is done not just once. You tend to do it every year or every 2 years. So if you miss it the first time, then hopefully something will come up the second time.
For any kind of bleeding, it should catch it.
From the lower GI tract, yeah.
Okay, well, I would like to really thank our wonderful speakers. I think Heather for sharing what is quite important. And I would like to tell you we have some refreshments out here if you'd like to come. There's supposed to be a networking social aspect to this. And
Would you like to buy a minute?
yes. Yes.
And I have a few quick comments too. There's also evaluation forms here on the right side going up the rows. So if you could fill those out and give some feedback on that, that'd be great. We're also videotaping the event, so if you know anyone who would be interested in this but wasn't able to come here to see it, then please see me and give me your name and number, and I'll send you the link to wherever I'm going to upload it to. And thank you again to our speakers. Really appreciate it.
And also, our next event is December 18th from 5 to 8 here. We're going to have Christmas carols.
You know anyone who's good talented, let me know.
No. You can just come and mingle, social.
As it is before.
Yeah.
Oh yeah, good food.